On the mic, grab a seat, it's the Kickback Science crew. Dr. Luke and his friends, ready to drop some knowledge true. Traveling the world, exploring health and wellness for you, kicking the science. Kickback Science, come vibe with us. Kickback Science, we'll kick the funk and discuss. We're breaking it down, moving to the beat.
The information we discuss in this podcast is not meant to be taken as medical advice. It is simply informative. We're not affiliated with any organization or institution, just a few guys talking science and having fun. Thanks for tuning in to another Kickback Science episode. We got a special one today. We got our very first guest, Dr. Salah Sharif. So, Dr. Sharif, he is from Libya in North Africa, where he lived most of his life. He actually worked as a physician in Libya. Came to the United States and did his master's degree at the University of West Virginia in clinical exercise physiology. Went back to Libya and then came back to the United States again to do his PhD in exercise physiology at the University of Northern Colorado. He is now at the Mayo Clinic doing cardiovascular research, which is the topic of today's talk. We're going to talk about the cardiovascular system a little bit and the number one killer of all Americans and actually everyone in the entire world. The number one cause of death is related to our cardiovascular system. So we're going to talk to Dr. Sharif a little bit, get some of his expertise about that. But before we do that, I just want to say hi, Dr. Sharif. Hi. So tell us a little bit about, what brought you to where you're at today. So, tell us about Libya. What was it like in Libya and what was it like working as a physician? And then what brought you to the United States?
Oh, first, it is my pleasure to be here as the first guest with you, Locke. And do you want back 10 years back, 15 years back? Oh.
Go back as far as you want.
Okay. So
what was little Salah? Like a little Salah running around in Libya, start from the beginning.
I'm not going to give you a more detailed specific with dates because I'm so sensitive with those. So I grew up and born in North Africa in mainly countries called Libya, and my homeland city is called Benghazi. My city is in the Mediterranean. I grew up on ocean. Yeah. Every time I wake up, I see ocean in the morning. And this, I think, if you ask me what you're missing at home, seeing Mediterranean.
Yeah, geez, I would miss that too.
Yeah, so.
It's a little different view than Rochester, huh?
In general, yes. And I grew up in middle class family. And I was the first generation student who went to School of Medicine in my family. And this must take me around 7-8 years to graduate. So the School of Medicine there back is you go to School of Medicine after high school. It's not like in here state.
So you graduate high school and then you actually start your medical school curriculum.
Yes.
That's how it is in a lot of European countries too, isn't it?
Yes.
Is the United States unique in terms of you have to go get an undergraduate degree for 4 years and then go to medical school? Is that elsewhere? Or is it pretty typical that when you graduate high school, you would just start medical school?
Actually, it's typical. Our system, like School of Medicine, is mainly to UK system. Is it mainly? Yes.
Yeah. It makes more sense that way. Because why waste all this money taking these classes in English and liberal arts and stuff? If you know you want to work in medicine, you should get to start that way. So I think that's cool that you did it that way. So it took you 7 or 8 years, which is pretty typical.
Yeah, 7 8. So it was first year is what's called pre-medical school. So when you study chemistry, biology, physics, those, English, those, and you have to pass. And then you're starting medical school. 3 first year is called medical basic science. First 2 years, you're going to study anatomy, physiology, biochemistry, pharmacology, microbiology, pathology, and then the last phase is 2 years. Phase is what's called clinical rotation, but those years is connected. There's no holiday, no off. So you're going to study medicine, surgery, pediatric, radiology, gynecology, obstetrician, psychiatry, all those branches. After that, you graduate. You have a 1 year internship. So you cannot take your diploma for graduation till finishing internship is 12-month internship. You're working.
Okay.
Yeah. There's a system, it used to be a system. But I believe the system need to be changed a lot, especially nowadays.
Well, that actually sounds similar to what we do here. So like for me, I have 2 years of coursework, or what we call the didactic years. And then you do 2 years of like around the clock clinicals, like you're saying, where you get experience in all these different specialties. And then you do your intern year of residency before you get licensed. So
no, internship is different than residency.
Okay. So you're not a resident yet, but here in the United States, you actually don't get, so you graduate with your diploma after your 4 years, but you have to do an intern year before you get your license.
Yes.
So before you can sit for your final licensing exam. So it sounds pretty similar in some ways though. Yeah. That's interesting.
Yes. I think license is one part of highly standard qualification for all to have a license. Yes. And then after I graduate, I work for emergency and trauma for many years.
Oh, wow.
Yeah, we work like in trauma, especially with casualty like car accident, stab wound, gunshot.
Wow.
And open like other surgery. Like yes, it's very tough work, man.
Jeez.
Yeah.
So you were working in the emergency department.
Yes,
in a trauma unit. See, I can't do that. So my wife, who you know, she works at a level 1 trauma center as a nurse and just thrives in these high intensity situations, like with the patients like you're describing, car accidents, stab wounds, gunshots, and all this. And you got to be so quick on your feet.
Yeah.
And I give so much credit to these hospitalists, these physicians that work in those environments, because, you know, you're making these like literal life or death decisions like that. And yeah, so I respect the hell out of you for that. That's amazing. How long were you working in that type of setting?
I believe I worked like 7-8 years. Yes.
Okay.
So then one day I realized, it's not my place, it's not my career. Okay. So I shifted back to academia. I joined physiology department as a teaching assistant, and then I got scholarship from the university to come to the United States. So first time I came to the United States was 2008.
Okay.
Yeah, at that time, I believe I was in Chicago. It was an amazing day. I lived in Chicago that time. For the first time, I was attending election of Obama.
Oh, really?
Yeah, so I remember the day he has been elected, I was in Grand Park in Chicago. Okay. And he had a speech. He was like maybe 200, 300, 400 meters from me. Yes. It was an unforgettable night for me that.
Wow. Yeah. So this is the first time you ever came to the United States.
Yes.
And it was because you got funding through the university to come to Chicago.
Yes.
Okay. And then you came to Chicago right as Obama was getting elected.
Yeah.
That's so
cool. I've been following. So that time I went to English school, and the teacher there, one of the assignment give us like Obama speech. When he speaks something, we have to study this speech. So that's why, yes. And Chicago is blue. Is a hometown President Obama. But that day was very inspiring for me to see first African American being elected.
Yeah.
It's historical. I think it's one of the historical event in the United States.
Yeah.
In the last maybe 1,500 years.
Yeah, and it's cool that you got to experience such a huge event in your life.
Yeah.
And correlate that with this inauguration of Obama, like you moving to the United States, like all this happening. That's cool.
And then I moved to West Virginia. So I started my program in the clinical exercise physiology at West Virginia. And
so what brought you, like, why Chicago? So what were you doing in Chicago? What was the funding that brought you there?
So it's scholarship. I got funded scholarship, including English. So English, I take some English to improve.
Okay, so to study English in Chicago. Gotcha.
And to study English, you have to come like one of the biggest city, let's say.
Sure. Okay.
With multi-diversity. So Chicago was one of the attractive schools and bring students around the world. So during that, so that's it. Yeah, it was. I think I lived in Chicago maybe 7-8 months. Yes, I remember there was the winter very harsh there. Yeah. but it was a very good experience. I mean, I learned from. Yeah, I think one of the most beautiful city I have seen in my life, Chicago.
You know, I've only been there one time, and it was in the summer. Thank God. I mean, growing up in Minnesota, I deal with the harsh winters, but I just always hear of how windy Chicago is. And because like here in Minnesota, sure, it can get cold. And if it's windy and cold, it sucks. So to be there with the wind, I imagine it's pretty horrible. I went one time in like 8th grade for a baseball trip, and that was the only time I've been there. I remember loving it, but I'd love to go back.
Yeah, you should go like especially in summertime. I mean, yeah. Okay, then I moved to West Virginia, mainly Morgantown, where it's like it's a university town. It's a very small town. Where's the main campus of West Virginia. I spent 2 years. My master is one of the most exciting experience in my life. I mean, 2 years in West Virginia, and during that days, I got my first kids. My daughter, she born there.
Oh, okay.
So even now, many years, I still remember those 2 years because West Virginia, there's some, I like it, I love it.
So did John Denver.
Yes. It's my favorite song, Take Me Home, Country Roads, I mean. And be honest with you, I wish one day back to work there.
So you spent 2 years there getting your master's degree in clinical exercise physiology. And then your daughter was born there. I didn't know that. That's awesome. And then after you graduated with your master's degree, then what?
So during that, it was in 2000, end of 2010 and 2011, something happening back home, actually in North Africa, is called Arab Spring. So I remember that time I was planning to go to school to finish my PhD. I was planning to apply many school and this. I already had a plan. So Arab Spring, it changed my mind. So I make decision I have to back.
Okay, so there was something going on in Libya that brought you from West Virginia back, and you had originally planned on continuing your PhD, but you had to.
Yeah, I had to
unexpectedly rush back.
I don't had to, but it was my decision. Yes.
Okay.
So Arab Spring is starting with Tunisia, then Egypt and Libya. So I had dream to see change my country from dictatorship to democracy state. Especially I've seen how following election Obama and how this important. And I had dream to see this might be happening in my country one day. So I backed, and it was very tough. I mean, it was a war to get off a dictator. And after a few months of fighting with helping support of Western community like United States, European countries, we get off the dictator. And 2012, 2013, everything was promising. I've been involved with working at the university, working at the hospital. I work and volunteer for NGO. I work with political. I've been involved with political. So everything was promising future. That time, if you ask me, hey, Salah, do you want to back the state? I said, no, I want to work. My country needs me. But there's another country, another people that don't want to succeed.
So you went back at kind of with this feeling of optimism in terms of like Libya was going to be able to overcome this dictatorship and turn into a democracy. And then you wanted to go back and practice medicine there, stay in your position in academia.
I did this, but my dream to be part of the transforming.
Yeah. You wanted to help transform your country.
Because it's historical. Mm-hmm. It's something, to be part of this is something historical.
That's really powerful.
Powerful, something you be proud.
Yeah.
So one day you can talk about your grandkids about this, what I did.
Yeah.
I did what I can do, but I failed. I don't know. I think, we failed. Because,
as a country, you're saying?
As a country, yes. We failed and we're still struggling, yes. It's not, it wasn't, is beyond our skills, we were more dreamer than reality. We trust more people than shouldn't be trusted. And there's some country, regional country, do not want you to transform to democracy because there's going to be huge, dangerous model for their regime because they are a dictator next door to you. If you succeed,
so then you're a threat to that dictatorship.
Their people to follow you. That's what's happening.
Yeah.
And there's a lot of stuff going on, but...
we hear stories about, these civil wars that are going on in a lot of these dictatorship countries. And, hearing you talk about it really just makes me appreciate where I am.
Yep.
You know, and I want to thank you for giving me that moment. And I love having those moments where you can step back and really realize these fortunes that you do have in your life. And, you know, being fortunate of where I grew up and that, because I can't imagine that must have been extremely difficult to go back, have this level of optimism and feel like you're becoming a part of something so massive, and then to realize that it's more out of reach than you had initially anticipated. Is that kind of what you're saying?
Yes, actually, yes.
Yeah.
Yes. So then after like 2012, 13, up to 14, it was very productive for me, the country. It was promising future, everything. However, in the middle of 14, at the end of starting the second war, civil war, and that was very aggressive, and I was against this war. And it's called like deep state, anti-revolution, corrupted money, what's called all those together, united to fight the revolution. And this lead to country divided. So during time, I have a very, I don't know how to say it, but it's like very nightmare when you see your beloved downtown, your street you walking when you was young, when you was a kid, your memory destroying in front of your eyes.
Wow.
Yes. You see the shops you went when you was a kid to buy ice cream, or the place you want to play is destroyed by bomb. Or when you see a tank in front of your house. Yeah. So there's a lot of story I can tell you about this. How civil war is so bad.
Wow.
Yeah. And how see your friend, you bury your friends. I've seen like friends. We were friends fight each other from other side. I seen cousin fight from each side. I went to family, they bury their sons. One of them fight each other one,
Wow.
in the other side. So the civil war destroy the community and destroy society. For what? For nothing. And this is very, very, very painful.
So this was going on in the community that you lived, the war and people dying in the streets. You got bombs going off, and gosh, I can't even imagine, like, how do you sleep? How do you, and you had your oldest daughter at this
Yes.
time point. You hadn't had your other two.
I have second one, Janice.
You did have the second.
Yes, she's born. Yes, she's
So you've
born.
got-
Yes, she just born. Yes, in Benghazi. Yes. So we say like a few days without electricity. We cannot go out. You cannot go out to bring food. Okay. I remember one night it was in middle of winter. I got severe right colic pain, and you know what's mean colic pain? Like renal colic pain. I got stone. So it was very severe. I don't have any medicine in my home. There's no electricity. There's no internet. You cannot call someone to cover you. And there's a tank in front of my building outside. And you hear the bullet in the middle of the night and pumping. You cannot go walk. So I had to stay all night in pain.
Oh my gosh. Because you couldn't leave your house.
Yeah, don't worry. To get pain killer.
Jeez.
Yeah. I'm so lucky, because I have a lot of friends, they lost their kids, sons, father, especially from what's called random bullet.
A stray bullet.
Yeah, street bullet. Yeah. People who walk, he driving, he got bullet and die. Why? Who is this? Nobody knows. It was very curious.
Gosh. And so that's going on. You said this is around 2017? No, 2014.
Yeah, 14 is up to 2017.
2014 to 2017.
Yes.
And you're living in this community during a civil war, and you're working. Are you still a trauma physician at this point?
No.
Okay. Because I can't imagine what that must have been like during a civil war. Working in the emergency room at this point, did you have colleagues that were doing that?
Yeah, you have colleagues, and they did a good job. Really did a good job, yes. And yes. Yes, I think so. I'm not sure, but those are places who have a kind of casualty and trauma and civil war. They have a good experience to deal with this kind of emergency.
Wow.
So then, that time, in 2000, I make decision. Okay, I'm done. I cannot stay here. So how we can get out of the country? The only country I know is United States. So I have to back to state. So you have to back state. You have two ways: as an immigrant, or as a refugee, or as a student. Refugees was I don't know. I have no connection. I have no to help. So I make decision to back as a student.
Okay.
So I was lucky. Friend of mine, she did the master's degree at University of North Colorado, and she's back around before Civil War, like few months. And she told me about University of Northern Colorado, and she introduced me to her supervisor, David Hydak. So I contact him, I talk with him, and he accepted me as PhD. So I get accepted as, I think is something around 2015. However, my application was late, so he told me I have to wait a year so he can sponsor me.
Sure, to get funding.
Funding and everything. And that will take a long time to back to state.
So you chose to come back to the United States. You needed to get out of your country, you're saying. You came back to the United States, and you wanted to do so as a student. Now, had you floated the idea around of getting a PhD before this? Did you want to go get a PhD? And did you contacted Dr. David Hydak at the University of Northern Colorado? Were you interested in his research that he was doing, and that's what led you to that? Or was it such a emergency at that point that you were kind of just seeing if you could get out?
Yeah, this is a good question. I mean, as I told you, my plan to do my PhD before back in 2011.
Oh, right. Yeah. Because you were already planning.
But when it started Civil War, I have to think how to get out, how to save my family.
Yeah.
This was my priority.
Yep.
The second, how back to school, and then how to PhD. So that time it was like there was no connection, there's no internet, so you didn't have any option. So I was like drowning in the ocean. First hand will catch to survive. That's why. So,
wow.
Yeah, but I want to do PhD. I want to do PhD.
Yeah.
I want to do exercise physiology. I want to do exercise physiology.
Yes. And so Dr. Hydak at the University of Northern Colorado, he was able to get funding, and you were accepted as a PhD student. So off to Colorado you went. And what was the area of research? And for the listeners that don't know the structure of a PhD, so how it works is it's similar to medical school in a way, where you go through a couple of years of coursework. You're taking all these classes related to what you're studying. And then the second 2 years, instead of doing clinicals like you would do in medical school, you're working entirely on what's called a dissertation, your independent research project. You have a doctoral committee that helps guide you through this, but essentially you have to demonstrate your ability to interpret research and to conduct research in order to get a PhD.
So, can I ask you a question?
Yeah.
So what's the difference between MD and PhD? That's the question.
So, in terms of what qualities that gives you, or what capabilities it gives you?
No. The word MD was for, PhD was for.
Oh, so MD is a medical doctor. A PhD is a doctor of philosophy.
Yes.
And yeah.
The second question. What the meaning of philosophy?
Philosophy. That's such a hard word to put a definition on. I guess ideas.
So can I say you are a philosopher?
Yeah, I suppose. I mean, having a PhD qualifies us to say we're philosophers, right? In a way.
So philosophy, I think, is a huge word. I mean, I think
it's hard to define.
Yes. So that's the difference between MD and PhD.
I'm discovering the drastic differences there really is in a clinical doctorate to a PhD. And it is so different. And I'm so happy to have gone through that, as I'm sure you are. You think back to your medical school and your PhD. I'm sure you had the same experience as me, where It's I assumed they were going to be very similar. They are in no way similar at all. But you get these separate qualities from both that helps so much. So
I think from my PhD journey, I learned one thing. I know nothing.
Yeah.
That's it. So I know nothing. That means I want to pursue my life to learn, for learning, lifelong learning. That's what my PhD.
Yeah.
Till now, I'm learning everything. Every day I'm learning.
I resonate with that so much. And so the Dunning-Kruger effect, and for the listeners who don't know what the Dunning-Kruger effect is, essentially it's this area that we deal with a lot in exercise physiology, nutrition, and medicine, where, especially now that everyone has a voice, people who don't know a lot about a particular subject tend to be the most confident in their knowledge.
Yeah.
And these are the like keyboard warriors, I call them, where they just sit and write stuff about different topics. As soon as you get into the world of research and studying things in more detail, you gain more knowledge, you get less confident. And so there's this confidence level that goes up when you don't know a lot. And the further you get into the research, it's almost like in the ocean. The further out you get, the deeper that water gets, the more unexplored this research is. You become less confident. And this is a really good thing to understand in this world in terms of if somebody's coming at you with so much confidence with some area, especially nutrition, exercise, and medicine, if they are so confident, that should be a red flag that they fall on the low knowledge spectrum of this Dunning-Kruger effect. So like this lifelong learning, I mean, and that was something that I appreciate so much from a PhD is like knowing how much we don't know.
So from my experience, my PhD, so when I starting my program, I think I started a year before you. So I thought I know everything, especially like in physiology, exercise physiology. And was that in my class. And everybody knows that. But with years, as I got deep after the camp exam, after proposal, after starting my dissertation, I said, what? There's something wrong, right? There's a lot of questions started pop up, and nobody knows the answer to the question. Mm-hmm. So as you know more, you realize that you know less.
Yeah,
I think it's a part of your brain getting mature, your mind, especially your mind, your thinking, you're getting mature, and how you to see things.
Yeah,
and one thing I also want to say to students: don't be ashamed or shy to say, I didn't know.
Yeah. Don't be afraid to say, I don't know.
We are human beings. It's so simple.
Yeah. That was hard for me when I had the same experience starting the PhD where I went in, I'm like, I'm starting a PhD. Like, I know everything. And you hear the statistics of like how little people get a PhD. And it just like almost made me feel really cocky with it and confident and like, I'm getting a PhD. What do you know? And then you get further into it and it's like, you get so humbled. And it's such a maturity thing, like you're saying, where it was really difficult for me personally, especially as I'm teaching classes, and I'm teaching classes to students who are at a similar age and some of them even older than me. And that was really intimidating for me because I felt like everyone was looking at me like, oh, this is just some young kid and he's instructing my class. Like, what does he know? And I felt like I had to be confident. And if someone asked me a question I didn't know, I felt like I had to just try to come up with an answer. That was so early on. And then I started to realize like, this is so inappropriate of me and immature of me. And realizing how much I truly don't know and being humbled and then knowing to say I don't know and not feeling ashamed to say I don't know. I want to say I don't know now. Like, and that's why I'm excited to have this conversation with you is like the I don't know leads to if you do know, then we can have a discussion about it, or maybe we can explore these ideas together. So yeah, I think I go on these tangents in this podcast, Salah. You're going to have to bear with me during them where I take these conversations in separate ways. But that's such an important quality that I feel that I gained from the PhD specifically, where it's important to say I don't know and to be okay with the fact that you don't know.
Yes. I mean, this is part of life process, man. I mean, learning. Yes. And there is some question like when I was during my PhD journey, what's the difference between, that's I'm asking you and your audience, between information and knowledge? Right now, we're living in information era. Everyone he get access to information with technology, especially now with the AI. You can get knowledge and information. You've seen a lot of people talk, they know information, but they not have knowledge. So I'm asking you how you differentiate that.
Okay. So you're asking me to define how I differentiate information to knowledge.
Yes.
Well, I kind of like how you started where you're saying there's so much information out there.
Yes.
Right? We all have access to this information. But knowledge, I feel like, is more like, what do you do with that information? How do you interpret that information? And I'll relate it back to the PhD, back to research.
How to apply it to real life, to daily life. Yes.
Yeah.
This doesn't mean knowledge.
I really like that.
And knowledge is a part of critical thinking.
Mm-hmm.
Yes. People have information, a lot of information about like exercise training time, but he doesn't know how this exercise intervention doing at molecular level, how this exercise change your genes, how exercise affect your muscle fiber, how exercise change your mood, how affect your glucose level. This is knowledge. And the knowledge is connected with each other. It's not connected with a specific topic. It's connected with integrative. Your body, your environment, earth, sky, you know what I mean?
To be able to integrate all this information together and relay it. I like, and now you're kind of dipping into the exercise world, which I love, because like you're saying, people have these ideas with different training modalities, like, oh, you shouldn't do high intensity interval training because it increases inflammation and all this stuff. But like, that's just something that somebody heard from somebody. And it's because people hear the word inflammation and are like, oh, this must be bad. But what they don't understand is like, what is leading to this inflammatory process, and why is inflammation in this context actually beneficial? How does that influence other organ systems and other disease processes? And yeah, so no, I appreciate that. So you went, now, I mean, we're diving into this exercise, so I'm going to take that tangent and go with it. Your PhD was studying exercise physiology, but you had more of a nutrition, metabolism spin to it a little bit too, right? Like, what was your main focus throughout your PhD? What kinds of questions were you exploring?
It's tricky. So my diploma title is PhD in Sport and Exercise Science. And you see this title, sport, that means something related to athletic, football, marathon, running, swimming.
Everyone thinks, oh, you must be a personal trainer.
Or something. Yes, sport, exercise, science. I think I had argued with some colleague and some professor. I think this title need to be changed.
Yeah.
What the study is called integrative exercise physiology.
Yes, I agree 100%. There are universities that are switching sport and exercise science to integrative physiology.
Yeah. So integrative exercise physiology.
Yeah.
So what's the word integrative? Integrative is, I think, connect your system, your organ, everything together work. Because your human body, every cells work with neighbor, with other cells. The cells in your heart work with the cells in the muscle at the same time. So you cannot separate. That's what's integrative physiology.
Well, yeah, everything's connected.
So my supervisor, Dr. Haidak, I want to say hi to him if he listen.
Shout out Dr. Haidak.
And he was one pioneer in chemotherapy. It's called doxorubicin and its toxicity. And he trying to how to evaluate or mitigate or prevent chemotherapy toxicity with exercise intervention and with supplement.
So he was looking, because, for listeners that don't know, doxorubicin is a very nasty chemotherapeutic drug that has this ability to go right to the heart, and specifically the muscle within the heart, right? And it creates this toxic environment for the heart that actually disrupts the function of the heart itself. So Dr. Haidak was looking into, okay, doxorubicin is very effective. We use it in a lot of cancer diagnoses. And he was looking into, does exercise play a role in protecting the heart from those nasty effects of this drug?
So he used an animal model, I believe mainly rats, and he did a lot of research and he published a lot, especially also with Dr. Howard, especially with aerobic exercise, rat, and how protect. And the data show that exercise is a delay or may prevent toxicity caused by chemotherapy. So chemotherapy, this doxorubicin causes mainly cardiotoxicity and muscle dysfunction, or called myotoxicity. So my research was interested in both, with the supplement is called creatine. And everyone who go to gym, he must know creatine. Creatine is amazing.
Yeah,
It's
creatine is huge. So you were studying creatine as it relates to toxicity from a chemotherapeutic drug.
Yes. So creatine so the question is creatine is what's creatine? How we can creatine? What's the main source of creatine? Do we need creatine as supplement as daily? Yeah.
So you have to come back for another episode.
Yes.
Because we should do just a discussion about creatine itself. I think there's so much to dive in there, and it'd be really cool to hear your perspective. I mean, like doing your PhD research, getting as far into this research world as you possibly can. I would love to hear about that. So I just want to kind of plug that in.
Yep.
You should come back. We should talk creatine sometime.
I hope so. Why? Yeah. I mean, yeah.
So that's what your dissertation was the supplementation of creatine. Now, you did animal models, right? You were using rats or mice?
Rat.
And
I love rat more than mice, Matt.
Yeah, I don't know. I told the listeners in the previous podcasts about my experience working in the animal lab, and I really didn't like that process of euthanizing them. I don't know. It just something felt wrong to me. I didn't do very well in that environment. But and I'm not saying like I'm PETA and I think we shouldn't do animal research. It didn't settle well with me, and I liked the mice because they were smaller, easier to handle. But yeah, continue.
Yes. So there's my PhD, and it's taken me like 2 years to study how creatine supplement with doxorubicin effect on cardiac muscle and skeletal muscle rat. Yes. And then I graduated in 2021. You remember that?
I do.
Yeah, it was amazing night. I remember, yes. And I'm lucky I was a graduate with what's called graduate dean citation or something. Yes.
Yeah, you got some award for, was it for your dissertation specifically? Your PhD research?
Yes.
And all, because, I remember getting our PhD together and how involved you were with the community, with the university, with the graduate school specifically, promoting people to come to the university. I'm not surprised at all that you got that Dean's Award when you graduated with your PhD. I remember listening to your graduation speech. You were selected as a person to speak, and that was an amazing
I was
ceremony.
lucky. I was lucky. I mean, I was lucky, and was like surrounded by good people, classmates. Yes, like you, David. It was the director of graduate student, and who else?
There's a lot of good people out there.
Jacob. Yeah, I miss him. Victoria, Leah, Luke. He's Luke, by the way. And Nick.
Shout out to all the UNC Bears.
Yeah, yes. There's a lot of, I mean, I lived like around more than 4 years in Greeley. It's an amazing city.
Yeah, no, I liked the University of Northern Colorado too. Like kind of like this hidden gem north of Denver, and the research and some of the most brilliant minds I've ever come across at that university. I loved it. So you graduated and your dissertation was studying creatine and cardiac toxicity related to doxorubicin. And so at this point, because, now you're at the Mayo Clinic involved in cardiovascular research, clinical cardiovascular research with humans now. So you're not working with rats.
Yes.
So did you after graduating with your PhD, you wanted to stick with cardiovascular research?
Yes, I think, yes. So I'm a big passion with the cardiovascular in general. Mm-hmm. Especially cardiovascular physiology, and I moved to my clinic as a postdoc. Yes, I work with my background in medical school, my master, my PhD, all those backgrounds to do cardiovascular research, mainly as preventive, with lifestyle intervention.
So you're studying how to prevent cardiovascular disease.
Yes.
Okay, and when we say cardiovascular disease, that can encompass quite a bit. What is your main focus with cardiovascular disease?
Right now, coronary artery disease and heart failure.
Okay, so when we're talking coronary artery disease and heart failure, now a lot of what we learn about in medical school, I love that you're talking preventative stuff too, because this is my bread and butter and also happens to be something that no one talks about in medical school. All we get in our medical school curriculum is this little statement where it's like, oh yeah, exercise is good for you. And it's a little bit more than that. This is hyperbolic. I'm exaggerating a little bit here, but there's no like actual lecture teaching us how to prescribe exercise, and especially as it relates to cardiovascular disease. But what we do learn is, so coronary artery disease, the gist of it is you get damage to these coronary arteries. And for the listeners, these coronary arteries are when your heart pumps blood. So your heart has to pump blood to the entire body to deliver nutrients, deliver oxygen, get rid of waste. And it's vital for our function. Now, the heart needs its own blood, right? It's delivering blood to the rest of the body, but it also needs to deliver blood to itself. And if it doesn't, it's not going to have the oxygen and nutrients that it needs to function. So these coronary arteries are the arteries that deliver blood here. And I'm kind of taking away your shine here by talking about it, but I want to just bring up what we talk about in medical school. So we learn that these coronary arteries can become occluded, and they get occluded by damage to the blood vessel wall, and cholesterol can kind of find its way through these damaged layers of the vessel, and these immune cells, macrophages specifically, will come and take up that cholesterol and make what are called foam cells. Those foam cells will release these inflammatory cytokines to kind of rebuild the blood vessel. It gets rebuilt, and these thrombosis, this process of thrombosis occurs where these plaques start to build and narrow the blood vessel diameter, and then you decrease blood flow back to the heart. And so what we're taught is you really don't get many problems until that coronary artery vessel is occluded to the level of like 90%. And so like from stable angina, which angina is chest pain, stable angina, that's less than 90%, right? 90% occlusion. Whereas unstable angina, where it's random, that's when that vessel is occluded more than 90% here. Now, I remember learning about this specifically. And cardiovascular physiology was one of the early medical school courses we took. And I remember learning about this, and we have this process where you go through this 10-year risk factor stratification. You determine what is somebody's 10-year ASCVD risk. So what is their risk of cardiovascular disease? If it's high enough, then you'll intervene. And if somebody has occlusion of those coronary vessels at all, why are we not intervening? And so, yeah, this is another tangent. Salah, you can interrupt me anytime because I'll just go and go and go.
So what I'm trying to say is called, what's explained is called atherosclerosis.
Atherosclerosis, right?
It's a disease of arteries. So atherosclerosis is a very complex process. So those atherosclerosis has a like risk factor. One of those factors is have a like hyperlipidemia, high lipid in your blood.
So hyperlipidemia, high cholesterol.
Yes, high body weight, physical inactivity. So how we know this person is physical active or not? So according to American College of Sport Medicine, you have to have a moderate exercise, 150 minutes per week. This is the minimum. Or 75 minutes of vigorous exercise, high intensity exercise. So if you less than 150 minutes per week, moderate exercise, when you say moderate, like walking, if per week, you're high risk.
So if you're less than 150 minutes of exercise or physical activity per week, then you're at risk of atherosclerosis, arteriosclerosis.
That's what ACM recommended, at least to do it 150 minutes, yes. And other factor is plus physical activity, hyperlipidemia, smoking, high blood pressure, high glucose. All those factors can lead to coronary artery disease. So the question is, those cause factors can be prevented, can be modified? Of course, yes, we can. You can.
Yeah. I mean, so we have all these modifiable risk factors that contribute to this disease. So there's a lot of intervention that we can do, right? Now, what happens when this disease gets progressed far enough along when somebody gets symptoms? Like what are symptoms of coronary artery disease? What are the issues of this disease specifically? Like what's happening to your physiology? Like why is this such a horrible disease? And this is the number one killer of Americans and number one killing of people in the whole world, right?
Yeah, according to WHO is around 18 million people died every year with cardiovascular disease.
18 million people
1,
dying
8
per
million
year.
Yes.
Wow.
Yeah. I also believe is the second or maybe the first leading cause of death in the United States of America.
And number one globally.
Yes.
Like across the world, this is a
according
problem.
to WHO.
According to the World Health Organization. Well, I mean, we'll take their word for it, right? I mean, so why is it, what is it actually doing? When you get these blood vessels that become narrow, or like, how are these things contributing to that? First of all, like, let's talk about the physiology of this disease a little bit.
What's the main function of the heart?
Main function of the heart is to deliver blood.
Pumping blood. I love pumping.
To pump blood.
Pumping blood. Why pumping blood?
Why is it pumping blood?
Pumping the blood is as a carrier. The blood is the bus or the car, taking oxygen to the cells. Mainly what? The brain cells. The oxygen, if you stop oxygen in the brain cell for a few seconds, minute, 2 minutes, you get fainting. You may get coma, die. So the heart is one of the most vital organ in your body. If your heart get disease, impact his contractility, functionality. So the pumping blood would be less efficient. More blood going to your tissue, less oxygen.
So your heart, and when you get coronary artery disease, it just becomes less efficient at delivering oxygen. And that's the main problem here. So like, are most issues that come down the line of coronary artery disease, are they related to ischemia and, like a drop in oxygen delivery to the brain and peripheral tissues and such?
Yes. As you said, like the cardiac is a muscle, is a tissue, it's cells. It needs blood. It needs oxygen itself. So when the heart pumps through aortic artery, from aortic artery is a process. Another artery is called coronary artery. Those supply blood and oxygen to cardiac muscle. So if those blood get down and oxygen goes down, it's called what's called ischemia. So when you have like stable angina, that means you have a low blood flow to cardiac muscle. So it's alarming. Unstable angina, so what differentiates between stable angina is very tricky. Stable angina, can the pain stop when you're resting? Unstable angina, no. Even you're in bed, you still have a pain. And then you have what's called myocardial function. Myocardial is the stage where the cardiac cell, part of cardiac, is dead. Function does mean, function is, I think is Latin word. Function.
Oh, infarction.
Yeah, it's Latin.
I don't know the origin of the word.
I think it's Latino. I think Latin. It's mean death.
So the myocardial infarction is death to these cardiac myocytes, or the muscle cells of the heart itself, and then it can't pump.
So this is one of the stages of coronary artery disease. So cardiac cells or cardiac muscle need oxygen. So when the oxygen getting less, you feel pain, chest pain. And the chest pain is one of the main worst symptoms. Yes.
So myocardial infarction, one of the telltale signs is angina. Angina is coming from the lack of delivery of oxygen. It's almost like this signal of a poor delivery of oxygen, and this is causing this chest pain.
Yes. So when you have someone have a heart attack, let's make it easy, heart attack, whatever type heart attack, angina, stable, myocardial, he go to cardiologist, doctor, he give him drugs, medicine, and he do procedures called PCI or angiogram, and do stent, and he feel fine. So one of the drugs he give him like what's called beta blocker, might be like AC inhibitor. So all those beta blocker make your heart beat less, not stress your heart, trying of some kind of vasodilator drugs, and treat the occlusion by invasive angio with a stent. So to make the coronary artery dilated, and you find your dog. So the doctor, he did a great job. You get off the pain. But the question here, you have to ask, is the cause, the risk factor has been treated or not? Yeah, maybe treated. He gonna give him like anti-lipid drugs, antihypertensive drugs. Yes.
See, that's what is, it's not just cardiovascular disease that issue is involved with. And I noticed this in medical school, and I think it's because of what we're talking about with the PhD and like having a little bit more questions more often than most people. But when you're talking about this intervention, and that's what we learn. So a patient comes in, chest pain, referred to cardiologist, or, if I'm a primary care physician, I'm going to check cholesterol levels. Let's say they have high blood pressure, high cholesterol, they're getting chest pain.
High blood sugar.
Yeah. And even if we're not doing a CT angiogram or a calcium score to test their heart specifically, we're going to prescribe a drug to try to lower those cholesterol levels, take the load off of the cardiovascular system, lower the blood pressure. So like the ACE inhibitor you're talking about, and then a beta blocker. So that's directed at the heart specifically. Let's make it so the heart doesn't have to work as hard, because we're already cutting off its oxygen supply. So why don't we just make it not work as hard? And then you go in with the stent, which is, for the listeners, that's opening up those coronary arteries. So we talked about the arteries being occluded or constricted. Think of it like a garden hose, trying to pump blood through a garden hose versus a straw. So what a stent does is, we've got this straw, what happens with coronary artery disease, a stent's just going in there and turning it back into a garden hose. So we're trying to just open it back up. And this is an invasive surgery. And so what you're saying, and I cut you off before you get to it because I'm kind of excited to talk about what I think you're about to get to. All we're doing is just treating that patient's symptoms.
Yes.
Why did they get to this point in the first place? Why do they need this stent? Why is their heart running out of oxygen?
That's why after all this procedure, the patient referred to what's called cardiac rehabilitation. So cardiac rehabilitation, I believe, is part of lifestyle intervention. So what's a cardiac rehabilitation? Is a secondary prevention program. Is a comprehensive program including nutrition counseling, exercise training counseling, psychological support, high lipid profile management, and tobacco. Is a team effort.
Oh, I didn't know that. So it's all lifestyle factors.
Yes.
So you've got this healthcare team that after you go through this stent surgery, this open heart surgery to fix if you have a myocardial infarction or post myocardial infarction, then you're getting referred to this team of people that is looking at, okay, we didn't actually fix the cause of this disease, and so it's going to happen again, very likely. So we need to refer you to a team that's going to make it so that this doesn't happen again?
Yes.
Okay. So a lot of people look at cardiac rehab and because the term rehab makes it seem like you're getting referred just so that you can get back to baseline of where you were before. You just had an open heart surgery. We got to get you back to baseline. But what you're saying is, no, it's much more than that. You're making it so you're way healthier than baseline. You're getting towards the root of that cause of coronary artery disease so that you don't end up back in the hospital with another heart attack.
That's what's supposed to be. Yes. So, all those with lifestyle intervention, especially with cardiac rehabilitation. So the data show that people, when they have less mortality rate. So I'll give you an example. So one of the main assessment, they measure VO2 peak or peak oxygen consumption. So data show the people data show that peak VO2 is the main predictor of mortality. That's meaning if you have a higher VO2 peak, have a good prognosis, have a longer life. So if someone have a low VO2 peak, it can be improved or no? Yes, can be improved. So easy. How? Exercise training. What kind of exercise training? This is another thing. It's need another big boss. What kind of type of exercise? High intensity interval, resistance training. There's a lot of options. It's dependent patient. VO2 peak. So what's peak VO2? There's equations called fake equation. VO2 peak equal cardiac output, how much your heart pump blood per minute, multiply how much your tissue or your cells or your muscle extract oxygen. So that means if you have a high cardiac output, have a high extraction of oxygen at tissue level, you're going to have a higher VO2 peak, have a higher fitness, have a higher life, good prognosis. I'm talking general, not just cardiovascular, general, in everything.
Yeah.
Even cancer population, every disease.
Yeah.
So VO2 peak is one of the most, I believe, as exercise, so as integrative, is one of the good predictive.
We had a podcast where we talked about exercise, and I brought up the research that you're referring to related to VO2 max. And VO2 peak for the listeners is an estimate of somebody's VO2 max. And
By the way, there's a big huge between max and peak. Not everybody he can get the max, but you can get the peak. I can't get the peak. I'm not gonna get my max. Maybe you are younger, you're healthier, you can get the max. So especially when you talk with clinical population, I think you prefer peak more than max. Max more, maybe you can talk with athletic people, like super athletic, like runner, marathon, yes.
So that's interesting. What I always understood was VO2 max was when you can directly measure what you're talking about, that the Fick equation of cardiac output, and then a VO2 difference, or like how much oxygen you're delivering to the tissues. We do that with like the metabolic mask that can measure those things. I won't get into the weeds there, but I always thought that that was a VO2 max because you're actually truly measuring oxygen exchange versus an estimate. When somebody's on a treadmill without a metabolic cart, then you call it VO2 peak. So what you're saying is that in a clinical population, people aren't able to achieve their true VO2 max with exercise. So
because there's a criteria. There's a criteria. One of them is there's like respiratory exertion, like RER.
Yep.
We have what's called RPE and how percentage of max heart rate. So there's a criteria together.
No, this makes sense.
So but people like we work with deal with clinical condition, sometimes like fatigue, leg muscle pain. So but there's a criteria for VO2 peak.
So you use VO2 peak more.
Yeah. So I think I don't know. It's very. I don't know how to say it, but in clinical side we prefer VO2 peak.
Okay, that's good to know. I'm going to start referring to it as a VO2 peak in the clinical setting. Then I appreciate you clarifying that. Now, we talked about though, like what is it about this peak VO2 or VO2 max that indicates so much? And it's like what you're saying. It is the number one indicator of all-cause mortality, the number one indicator of whether or not you're going to die of disease because of what you're saying. It's not just how your heart's pumping. It's how the rest of your body is taking up that oxygen, utilizing it. So it indicates the metabolic health of your entire body.
So at tissue level, when a tissue needs oxygen, extract the oxygen from the blood and they go oxygen to the muscle. So the oxygen, where to go to tissue? Go to what's called mitochondria. Mitochondria is one of the most amazing organ in the human body. Is one of the secret. Mitochondria use oxygen to produce what? ATP.
Energy for the cell.
Yes, for the human body.
Yeah, back in elementary school biology, well, I don't know if it's elementary school, but
the mitochondria is the main metabolic processes in the human body happen in the mitochondria. Again, how make your mitochondria healthy mitochondria? With lifestyle intervention. So when a human he go to exercise, and to go diet. Diet is a huge word. So we have to be careful about this word.
The nutrition industry, the nutrition research itself.
Yes,
a little cloudy.
So exercise. One of the things exercise is doing at mitochondria level. So what's happening in mitochondria? He supports your mitochondria by increasing the size of mitochondria, make your mitochondria more efficient to extract oxygen, to produce ATP, and at the same time to produce less oxidative stress, what's called ROS.
Reactive oxygen species.
And this is the most causing disease, especially cancer and metabolic disease. Again, mitochondria, I think, is one of the main target therapy in the future. And we can improve our mitochondria with lifestyle intervention through exercise, healthy diet, healthy habit, stress management, social support, stop smoking, stop drinking alcohol, all those. And we call this intervention lifestyle. That means you have to do it for your daily life, total rest of life. That's why. Doesn't mean if you stop doing this for 2, 3, 4 months and then you stop it. No, you come back. So you have to do this intervention for whole life. I believe the muscle has been created to walk, to exercise. Your muscle
I
love
love that.
Your muscle love to walk, to run, to do something. You make your muscle happy, and when the muscles work hard or running, exercise, send cytokine or myokine to other body, to your
Send
heart,
signals to the rest
to
of the
the
body.
brain, to talk other. As those talk much about between the muscle and the brain and the muscle and the heart, as you have more healthy. And there's a lot of research talking about this myokine. And there's a lot we did not know about what doing this muscle.
So
The myokine. So in the School of Medicine, 20 years back, gland secrete hormone. So what's the definition of hormone? Is a material secreted by organ go through the blood to have effect to another tissue.
so it's an endocrine organ.
Yes, endocrine. The muscle, when you have exercise, the muscle is going to be endocrine. Secrete myokine or cytokine to go to blood, go to the brain, go to heart, to pancreas. We did this a lot.
So you're saying we should think of the muscle as an endocrine organ because it has the capability to communicate
I
with the brain.
believe
communicate with the heart.
exercising active muscle.
Okay, so you're saying exercise allows the muscle.
If not, they're going to send you bad myokine.
What do you mean by that?
This is a huge topic, man. So I believe exercising muscle, sending myokine.
Yep.
That myokine like IL-6, okay?
That's a funny.
Yes.
So you're talking about the muscle being an endocrine organ because it releases what are called myokines.
Myokine.
People probably have heard in. I bring up COVID when I try to explain what like a cytokine is. You hear people get diagnosed with COVID, they get this cytokine storm. It starts this inflammatory process, leads to a lot of organ failure down the road. Now, a cytokine is what the immune systems release. A myokine is the same thing, but it's coming from the muscle. And so it's the muscles releasing these components, including those inflammatory markers. Like you're saying IL-6. Now, IL-6 has this horrible name to it.
I have a good story with the IL-6 during my PhD. One of my professor, Dr. Nicholas. Yeah, you remember him?
Oh, yeah. Dr. Pullen? Heck yeah.
Yeah. So we talk about IL-6 as a cytokine, as a myokine. And in my camp exam, he bring me this question. I think I wrote like maybe many pages about IL-6. Is amazing and confusing, yes, and very careful deal with, yes. And how this affect if coming like from exercising muscle or coming from immune inflammatory states is different. How does it affect the same chemistry, but they have a different action, depend on your situation. We didn't know yet about this.
Yeah, IL-6 is such a mystery. And like so many research articles, people will publish research showing like, oh, this intervention decreased IL-6, therefore it's beneficial. It's like, there's such a mystery behind what that actually means. Yeah. So I think there's a lot to interpret behind IL-6. But
so let's go back about how it exercise intervention. As I told you, for cardiac rehab, the exercise is the main component of cardiac rehabilitation for training exercise. So the patient came, we do assessment, medical history, body composition, exercise assessment. We measure VO2. If he cannot, we go 6 minutes walk. There's another quality of life assessment, like another questionnaire, and then we have to so you cannot treat patients the same. It's different from one to one because everyone has a special case and special goal and special capability to do that, and special different resources. So you have to be the treatment during cardiac has to be individualized or personalized. So what's the best exercise he like? What's he best? So you have to think about those stuff. Be sure that patient he do something he want to do it. He like it. He love it. Yes. For example, for me, I don't like biking. If you want to, I do treadmill. Okay. But if you have to do bike, no, I don't like it. I don't know. Yeah. I don't like it.
And I think that's
something personal. I don't know. Yes. So I love to running. I love to go treadmill. Okay. If you want to do treadmill, how many you want to do? I want to do 1 hour. I can do like 15 minutes. You can do 15 minutes and 1 hour and you get the same benefit. But this is how to do that.
So you're saying you do this initial assessment for cardiac rehab and
yes.
you're just trying to figure out as much information about baseline health, but also what type of exercise would this patient be likely to adhere to long term?
Yes. Especially some people have other musculoskeletal knee problems. Patient cannot walk. So there's a lot of options. So there's some, so individualized, yes. However, at the end of the day, he should exercise. And when we say exercise, including walking, I believe the most important exercise type is walking. So simple, just walk.
I like that. People always wonder, do you have to go to the gym? Do you have to get on a treadmill? Do you have to get your heart rate super high? But you're saying the best benefit comes from walking?
You go to the gym because you want to do socials.
Yeah.
You want to see people. You want to talk with people. That's it.
So what do you mean by it's the best form of exercise, walking? Do you mean that because people are more likely to do it and they'll continue it long term?
It's simple to do it.
Yeah.
It costs nothing. It's very effective. Data show that is very enhancing all aspects of your health, from the brain to all the parts of your body.
So you're saying walking is the best form of exercise just because of adherence. So I want to clear that up for people in terms of that doesn't mean you shouldn't be going to the gym, getting on the treadmill, getting on the bike. Like getting your heart rate up higher from running and doing higher intensity is going to have benefit to it. It's not to say what you're not suggesting. I just want to clarify for people. You're not suggesting that people walk instead of other types of exercise, right? Like
yes.
It's totally individualized. So when people go to cardiac rehab, I mean, you're trying to individualize their exercise program so that they'll adhere to it. Are you just walking at this point? What types of workouts are you doing after open heart surgery? Are people able to lift weights? Are people able to bike, run? At what point do people get there? How do you monitor that? What's this model of cardiac rehab? You're working with such a high risk population here. How do you make sure that they get back to exceed their previous function?
So this is very long process, depending on, as I told you, assessment of patient at baseline.
Okay. So it all just depends on that initial assessment.
His initial assessment, what his main disease, why he's referred, and the patient what he wants also, and then how's his VO2 peak, or how's his body composition, and also what his main goal. Some people come, hey, I want to back to work like as soon as much I can. Or people I want to live longer. I want to do disease. As I told you before, the main component of cardiac is exercise training. So exercise can include aerobic exercise, whatever you use, treadmill, bike, resistance training, stretching, flexibility.
So you're incorporating everything: resistance training, cardio, flexibility training. Now,
I don't know, but as a personal, I prefer starting resistance training as I getting old. Resistance training, yes.
I say that too. As we age, people are less interested in building muscle, it seems like. But when you age, you lose muscle. Yes. Muscle atrophies. That's the most important time to try to gain and preserve muscle. So I totally agree with you. Resistance training.
Most of people with cancer, what the main cause death in cancer?
The main cause of death with cancer?
Cancer population.
Organ failure?
Cachexia.
Cachexia. Huh.
Cachexia. Repeat this. Cachexia.
Cachexia.
Yeah. Lose muscle mass.
So the main reason that
one of those, yes.
Wow. No, I did not know that. I feel like what we learn is the tumor disrupts the actual function of that organ.
I think, yeah.
But what you're saying is the loss of muscle tissue that results from cancer is causing. Now, how do you die from a loss of muscle specifically most often? So you're saying this is the number one cause of death in cancer. What does that mean?
This is a good question. I don't know. I have no answer for you.
I suppose we still don't really understand the mechanisms of why cachexia is happening. But
losing muscle is not a good thing. That's it.
Yeah. So because you're losing that connection to your brain, to your heart.
You're losing mitochondria.
You're losing mitochondria. So you're saying, you're coming back to the mitochondria a lot here. I like that. Speak a little more on that, because I know the mitochondria is important for metabolic health, but you're saying that these mitochondrial disruptions are the reason, you said cancer and metabolic disease, right?
All disease, I believe.
All disease.
I think so. Up to now, yes. Mainly metabolic, yes.
Speak on that a little bit more. I'd like to pick your brain on this.
Metabolic disease, and the cancer is a metabolic disease, yes. Yes.
There are a lot of theories. There's a lab out in Boston that is exploring this idea of, I can't remember the main PI's name there, but this idea of like cancer initiating within the mitochondrial DNA itself.
So the question, how can exercise training, especially aerobic exercise, enhance your mitochondria and make your mitochondria more healthy, more efficient, more young mitochondria, even you are 70 or 80. Exercise can make your mitochondria more younger. So the exercise training, merely aerobic, enhance what's called BCG1 alpha, and this is one of the amazing who enhance mitochondrial function, mitochondrial proliferation.
Yeah, so you get more mitochondria. They're not just working better, you get more of them.
Exercise training change your genes, improve your genes, enhance your mRNA to induce or produce healthy protein that your mitochondria needed, and then your mitochondria can work more proficient and healthy to produce ATP and less reactive oxygen species.
So the reactive oxygen species, that's what you're saying is tied to all these disease conditions, because really what reactive oxygen species, it's kind of in the name.
Yes.
They're very reactive to other components of the cell.
One main thing, do bad thing, reactive, because it's going to affect the disturb the amino acid and causing mutation. And those amino acids is a part of DNA. And there's something happening at genetic level. It's causing disease.
So the reactive oxygen species disrupting actual DNA structure and these mutations.
During amino acid, yes.
Yeah. Yeah. And so with exercise, you get an increased mitochondrial content. So the amount there, the function is there. And then you have this impact, you're saying, on the actual gene expression within the cell to make more protein, make more of an efficient structure of the cell that's going to influence other organs and influence your entire physiology. I like that analogy of like tracing it back to the mitochondria, because that does make sense. I mean, your mitochondria have their own signal mechanisms, and when the mitochondria don't work properly, that's when you get this release of cytochrome C, this signal of apoptosis. So that does make a lot of sense. If your mitochondria aren't working well, they're going to signal for that cell to commit suicide. Mm-hmm. You know, that's where apoptosis starts. So yeah, if you have healthy mitochondria, you're not going to go through this apoptosis, damaging the cells, damaging the organs, and also this reactive oxygen species damaging the DNA, you're saying. So improve mitochondria. Now,
I think it's one of the most competent mechanisms to improve your health in general.
Is to improve mitochondrial health.
Yes.
Is the biggest thing you can do to improve your health. I find that very hard to argue with.
Exercise as a therapy intervention is heal your whole body, even your brain cells, your brain, memory, hippocampus, thinking, your heart, your blood vessels, your muscle, your pancreas, insulin secretion, glucose uptake, liver, lung,
immune system.
So let's see, simple. So let's back to cardiovascular risk factor. He can help lipid profile decrease, atherosclerosis, antihypertension, increase glucose uptake, enhance insulin sensitivity, decrease your body weight, decrease fat mass, all those with exercise training.
Yeah. So
I think it's more comprehensive for your body.
I like that, because so you're talking about the largest risk factors that indicate the greatest indications of your risk of coronary artery disease being high blood pressure, high cholesterol, body fat, insulin resistance, and just increasing mitochondria.
Including stress management. Keep exercising, enhance your mood. Mm-hmm. I think enhancing secretion like endorphin from brain, so enhancing your mood. So you be less stressed, yes. And calm you down. How do you know that? If you exercise like for 3 months, your resting heart rate after a few months going down. And that means your heart beat less. That means heart consuming oxygen less. When your heart beat less, the cardiac cycle increase time. So when the cardiac cycle, the resting time increase, dilation time increase, more blood coming to the heart and more blood pumping. So that's so simple.
Yeah, your heart just becomes so efficient.
So beta blocker, they do the same. But exercise training do the same.
So exercise is a beta blocker.
No. But beta blocker do not enhance your contractility. Be careful. Decrease your contractility pump. Exercise enhance your pumping. Enhancing what's called the muscle contractile protein. When you talk about myosin, those proteins enhance it. Enhance the bridging during the muscle. That's exercise. Enhancing calcium secretion that muscle need to contract. This exercise do it for your heart or for skeletal muscle. So I believe exercise is more. I cannot talk about just heart. Is heal your body.
Yeah. So from a cardiovascular perspective, I mean, this is your area of research. This is your area of expertise. Now,
I'm not expertise, man. I'm not expert. Well, I'm learning. Believe me, I'm learning.
We're always learning, right?
I'm learning, man. Believe me, I'm learning. Every day I'm learning.
Yeah.
And I want to tell you something. The most thing I learn when you work with data, I learn a lot. And data make me open a lot of question. That's why something I like it, and I love to do it every day. Work with data.
So you're saying data has taught you more than anything?
Believe me, more than...
That's powerful.
Yes, believe me, more article, more. It's amazing.
I wish everyone kind of had that same thought process because I think you really can.
I think everybody has, yes, but yeah, everybody know they do it, but I don't know.
Yeah,
but they don't. Yes,
I always try to encourage people to but the problem is
because we have a data, you analyze it, you can argue with your data.
Yeah, data's data.
Yes, yeah, because you take with data number. with yes.
Yeah.
Yeah, I'm learning a lot from data every day.
Yeah.
And this, I feel like, as I told you, I feel like, oh my gosh, my postdoc is my second PhD. To be honest with you.
Oh man, that sounds.
I told him
my stressful.
No, it's not. It's my second.
Well, in the context if you're continuing to learn, which I appreciate, but I mean to relate it back to your idea of the mitochondria and such. I don't want to shy too far away of the cardiovascular effects here. So when somebody comes in for cardiac rehab, I mean, you're involved in this area of study showing that if you do exercise after you have any sort of cardiac intervention surgery, does this include things like a valve replacement or other cardiac surgeries? It does.
Yep.
Yeah. Okay.
Yes. I think according to American College Cardiology and American Heart Association, patients who have like coronary disease, heart failure, transplant, CABG.
So anything cardiac related.
Valvular disease, yes.
Yeah.
Valvular disease is yes.
And so then they're going into cardiac rehab. And my understanding is it's insurance covers 3 days per week for 12 weeks usually. Okay. And so after that 12-week point, the goal is to have educated the patient enough about exercise and how to exercise that they will continue it long term.
Educate more about disease and health and diet, nutrition. Yes.
And
yes, it's a very comprehensive program. Is a team effort program. It's including cardiologists, nurses, exercise physiologists, dietitian, social psycho support. Is a team effort.
So this exists in pulmonary rehab as well. Similar model, insurance covers it. I know you're not in that area of research, but...
Yes. There is now pulmonary rehabilitation, yes. Especially with people with pulmonary disease.
Why...
And there is a cancer rehabilitation.
I know, but... So there's oncology rehab, but insurance companies aren't touching it. And that's the frustrating thing. Is like, you're talking about how exercise influences all these other diseases, but why is insurance only covering a 3-day per week, 12-week program for cardiac and pulmonary disease when the research is so clear in terms of what it is or what it does for benefiting cancer patients? And then not even that, like, why are insurance companies not even, I don't want to put it all on insurance companies. I'm talking like medical school curriculums, hospital administrations, like, why are we just doing this after this disease occurred? Like, at what point are we going to get to, why aren't we doing this exact model of cardiac rehab, but doing it more like a cardiac prehab? Like, if this is the number one killer of anyone in the world, why don't we address these risk factors before they end up in the freaking hospital in the first place?
I'm asking the same question to myself. I do not have no answer right now. It's more about the system.
Yeah, but I think the system's just kind of messed up.
But I think it's directed going, yes. I think lifestyle intervention is going to be one of the primary line of treatment of multiple disease.
Yeah, prevention should be.
Prevention is future, yes.
Yeah. I hope it gets to that point. I mean, you can't, like you're saying, you can't deny the data. Like, when you look at the research showing how a low VO2 max increases your risk of mortality like 8 times more than smoking cigarettes, that should be a wake-up call for people in terms of like what benefit exercise can provide. We banned cigarettes. You know, all this work went into this political initiative or public health initiative to drop cigarettes because we know it's associated with lung cancer and high blood pressure.
Does it take time?
Yeah.
More awareness, more research. Take time. I mean,
I just like to get fired up about it.
Yeah, yes, and you need to talk more about this issues.
Yeah, I don't know. I mean, with how much funding goes into research and where a lot of the funding is directed and where a lot of the funding comes from and the affiliations that a lot of hospitals and pharmaceutical companies and insurance companies have with a lot of these funding resources, and like, I just wish there was a better structure in terms of supporting lifestyle intervention research. Because what you're saying is we need more research. You know, it takes time. You know, as we gain more knowledge, then we're going to be forced to adapt to this information.
So the question here, I'm going to tell you a story. When I was in medical school, I did my internship in CCU, cardiac intensive care. Patient will have a heart attack. That time, the doctor advised the patient to rest, even after discharge, to rest for a month, weeks. Cardiac rehab, when it started, I think 70s, there's many places around the world they have no cardiac rehab, including my country.
And they...
Yeah. And
so before cardiac rehab...
There's some doctor over still recommended their patient to stay sitting in the bed after heart attack.
That... You know this story, but I'd like to share this story because it reminds me of something that happened to me personally. So when I went in, I got an EKG with my primary care physician. I just went in, I got an EKG, and it showed what's called right axis deviation. And I won't get into the weeds about what that is, but essentially like there was concern of my ventricles being too large. And I have a family history of cardiovascular disease, and I've learned so much about how family history can play a role. And so I was like, I better go get this checked out just to be safe, because I know about prevention. And if I know I have this added risk factor, then I want to get ahead of it. And so I went and I saw a cardiologist, and it was determined that I had ventricular hypertrophy. So and for the listeners that don't know, it's enlargement of the ventricle of the heart. And your heart has a right and left ventricle. And when these ventricles become enlarged, it's usually, if it's pathological, meaning it's associated with disease, it's in the center of the heart, right? It's that ventricular septum that becomes enlarged. And patients that have that happen, this cardiac hypertrophy, can't pump blood very efficiently. And then you get these diseases you're referring to, Salah. And so I got really worried about this ventricular hypertrophy. And my cardiologist, so I'm freaking out. And he's like, it's likely athlete's heart because you're exercising so often. And I recommend you do less exercise, and that you do, I can't remember what he said. It was some like made up number of just aerobic exercise. Because I told him that, I was doing mainly resistance training, higher intensity. And so his advice was to stop exercising. Now, of course, I did not take that well. So then I reached out to you and was like, hey, you study, heart failure, and having cardiac hypertrophy can be an indication of heart failure. And I was just told by my cardiologist that I shouldn't exercise. And so your response to me was like, whoa. That is the opposite of what should be done. And so you told me, come down to the Mayo Clinic, go see a cardiologist there. And then you can actually test this and do a cardiopulmonary exam and determine if you're at risk of any cardiac complication with exercise. And so you had me go down and I did that whole protocol and realized there is nothing pathological going on with my heart. My heart is in great shape. It's functioning perfectly fine. And all this, it was essentially just like data artifact. Because when we did this exam at the Mayo Clinic, we found that it wasn't a problem. And
it was athletic heart, I think.
So, yeah, I mean, and we could chalk it up as athlete's heart in terms of like my heart was just larger. I like to say I just got a big heart.
That's what exercise make your heart large. That's
yeah,
awesome.
but in a non-pathological way, right?
Yes,
because
yes.
it's efficient. Now, had I been just some individual of the general public, I would have trusted that cardiologist and started exercising less. And then I probably would have got heart failure down the road. So I think that's such a horrible message to send.
I think the last few years, starting what's called sport cardiology, focusing about athlete heart. And interpretation of ECG data, EQ, is different from regular population. So if you go to athletic, he do your ECG. He doesn't know you. He say you have a problem. Your heart looks big, ECG looks different, it looks disease. But it's normal for athletic.
So you're saying that like the ECG, the echocardiogram, the images come up pathological, and that's what happened with me?
No, it looks different if you have who has a good experience with athletic heart, with sport cardiology.
Okay, so...
that's what I'm trying to say. It's very confusing. You see the first time it looks like problem because your heart is large, okay? But it looks large from the image. But we didn't know, okay? So what's the difference between pathology and... Pathology have a more fibrosis. Athletic have a more muscle, okay? And this is very interesting. Also, ECG, you have a deviation, you have a hypertrophy. This is ECG, so yes. If even for me to give me ECG with some athletic heart, he has a problem?
So...
I remember one time in school, a teaching class, I have a student, his heart rate, he was 35, 40 in the University of North Carolina. And first it was, oh my gosh, his very heart rate low. But he looks fine. And then I asked him a question, what do you do? He told me he do I think kind of sport, marathon or something. He's running a lot. I say, oh my God, you're super healthy. I watch you have a heart rate, resting heart rate. It was 40, 45. In the same times, if another patient, 50 years old, with heart rate 40, he's in shock.
Yeah. Yeah. See,
that's the doctor has to be smart.
Yeah.
That's what was called knowledge. How to analyze your knowledge, how to think and really make decision about this.
Yeah.
I mean, yes. And this is from experience. I mean, I think now is starting, it's just not in Europe, even in Europe, is about sport cardiology. So I have another story I want to tell you about what's called athletic screening. So if you go to Europe, they have more updated, more qualified for athletic screening than United States. And there is the FIFA, is the Federal Football Federation. What about the football? I mean, it's called soccer.
Yeah. We won't get into that debate.
Yeah, so they have
it's called soccer, but
they have athletic pre-athletic screening is have a term. This including his medical history, ECG, and echo, and blood test for young athletic.
And the reason that they would do this athletic screen is because what you're saying to me, where if you're an athlete, and I'm not an athlete at all, but if you're an active individual who's had these cardiac adaptations, then somebody who's not familiar with an athlete may interpret your echo or ECG as being high risk.
Yes.
And so they have a separate screening.
Yes.
Yeah, I think that should be taught more in medical school for sure. If the data are out there, like you're saying, but I mean, you did say this is in the last 10 years, the research has demonstrated this. Mm-hmm. So for the listeners, if you're an active individual, would it be more beneficial to seek a cardiologist with a sports medicine background if you want to get an EKG or echo?
I mean, this is a good question. I mean, I don't have a right answer, I think, for it. As I told you, I'm not a cardiologist.
Yeah, I don't want to. Yeah, so
But
I don't want to
what
give
is-
advice or anything.
What
but
is sports cardiology? That means he see athletic daily patients. You do them screening, follow them. I'm not, but I think, as I told you, in Europe, especially football, every club has a like special team, including cardiology, who follow the player, do a screening. You're doing every year, including V2 peak or V2 max, also used for athletic. Is one good indicator for how fit you are. for
heck yeah,
sport.
especially when
Yes,
you're playing
so-
soccer.
So I think so. That's what the part of process. Yes.
Well, hopefully we get there here. I just, it made me.
So one thing is about those issue is what's called happening athletic, what's called sudden death. First is very low incidence, but the problem with athletic, especially athletic, he died during the event or the stadium with 1,000 people watching them in live and million around the world watching them on TV is very tragic and very effective. You see young who collapse.
Yeah.
And we have seen this in the last few years happening in football and in Europe.
Is it happening more?
Yeah,
Now?
no, but it's
People
not
just see it
But
more.
the effect is very tragic.
Yeah.
Effect on all community.
Yeah.
Yes. And my cousin, when I was in West Virginia, he died. Collapsed. He during playing football with his cousin. He's not athletic. He died collapse. He was young. He was like 15, 16 years old.
So what's happening when like an athlete collapses dead if they're otherwise healthy? Like, because people get concerned about, because you have to say exercise has risk. People have died exercising, and I think it sends a bad message when you say it has risk, because everything has risk.
No, because-
getting in your car and driving to work has risk. But when we're talking risk, you're saying it's so minimal. But what is actually happening here?
So, as I told you, it's very low incidence. I think the missing screening, maybe have a like congenital disease. One of those called cardiomyopathy. Is not being diagnosed, it's been not seen. We have-
Sure. Okay.
The patient has no symptom, has no complaint, has nothing.
So there's some underlying pathological issue as opposed to just
Yes.
exercise causing the death.
That's why, like, for example, FIVA make those screening for
Yeah.
whole screening.
Oh, sure, okay.
Try to prevent those.
Yeah.
They'll do screening, including medical history, ECG, even I think chest X-ray, blood tests, and echo.
Okay.
Yeah.
And they do that every year.
Yes.
Now, I don't want people to be nervous about exercise, thinking that exercise is going to kill them. I mean, exercise has a risk just like anything has a risk. But
I can make it so simple. I mean, if you're healthy, you have no issue, you have no disease, just go exercise. It's make it part of your daily life. If you're sick, you have a problem, you have to make consultation. Health provider, primary care, cardiologist, whatever you have to take. And then he will refer to specialist, someone like you, exercise physiologist, who can deal with you. And what's the best exercise, what's the training, and how progress to get your goal. Take it simple. The question, do you need more awareness about this? I think we need more. Yes.
Yeah.
Yes.
I think, the next step here, and something that I hope happens soon, is that this needs to be implemented into medical schools. Because, having been part of the medical school curriculum, I mean, you've seen just as well as I have, physicians don't know anything about exercise and nutrition from their medical school curriculum. You're not learning anything there. But people in the public go to their physicians to try to learn. They're their trusted source. I'm not trying to fault the physician here at all. I'm faulting the system that, they've gone through, the curriculum they've gone through, and their practice and such. And based on, this conversation, and this could go on forever. I've already taken up a couple of your hours here, or a couple hours of your day here, Salah. But, really the underlying message here is we've talked about all these benefits and all that help that exercise is going to provide in preventing and treating these conditions. I just hope that we can just start using some of this information and put at least one little class in the medical school where it's like, hey, future healthcare providers of America and around the world, here's some education on how to prescribe exercise. A cardiac rehab model would be great.
Let me talk about my experience. I'm not familiar with the American School of Medicine system here. I think for me as a physician, or you as a physician, to understand how exercise itself affects on your health and heart, blood, vessels, brain, lung, muscle, and again mitochondria. How does it affect as a physiological process, as genetic process, as metabolic process, as synapse process, as connection, everything, and exercise. And what's exercise? What type of exercise affect, and why aerobic effect is different than resistance? And why regular aerobic different than HIIT or high intensity interval? Kind of a question. And why yoga is different than those? Yes. What's about other exercise, martial art exercise, all different exercise? We need how to affect them. I think this is the main thing have to be added to the curriculum.
So
this is the main thing because you be aware that as a physician that exercise intervention can use these as non-pharmacological intervention to treat multiple disease and chronic disease. Okay, let's back to my experience. After my graduation from my master in West Virginia, Montanair, I'm so proud of this university. I love it. I love it, man.
Country road.
Take me home. Almost heaven, man. I love it. I love it. Yes. I was so exciting about exercise physiology and how it's amazing, cardiac rehab. I wanted to test my experience. It was just 2 years to School of Medicine, my School of Medicine. One thing as a clinical site at cardiac lab, where the doctor doing exercise testing, stress exercise test, not cardiopulmonary exercise, just stress exercise test, just with ECG and treadmill and diagnosis. I realized that all physicians doesn't know how to interpret data from that. They're just only focusing in ST elevation, ST inhibition. That's it. I see struggle guys, that's wrong. From that test, I can dig a lot of data. Tell me the patient, he need go further on, send him home. There's one story. I did stress test for patient. His brother is one of my friends, and he referred by cardiology, and he was like he has a lot of issue around his life right now time. And he do Bruce protocol. Do you know what I mean, Bruce protocol?
Yep, Bruce protocol, the incline treadmill test.
And then he got like 4th stage, 6th stage, and he stopped exercise. I stopped the ECG. I told him, go back home, keep exercise, keep this. Your heart is perfect. I see. And he said, how do you know that? He said, you showed me that. If you have a heart, you have a problem, you cannot get this stage.
Yeah.
Nobody gets this stage. Me and I cannot get this stage. You do amazing. Back to your life, organize your life. And he hugged me, give me a hug.
See, how simple would that be?
So simple, because with that I can get exercise time, I can measure function capacity, I can measure heart rate response, peak heart rate. If he get like more than 90% of his heart rate without any chest pain, that's, oh my God, that's good. You know what I mean? Yeah.
There's that reminds me of
and
this.
We see that your recovery, heart recovery is good. And there's no ECG during the recovery. Blood pressure respond well. They're still going up, they're still going down. It's perfect. Everything. Why think about they have a problem? Why he go further do like angio this stuff? He have a chest pain. There's something wrong with him, like something problem. Believe me, yes. And then this make patient happy, but this make me problem with the cardiologist. I say you do wrong what you say. No, you do not. I say not mad. That's what I'm saying. Data saying this.
Yeah, the data say that.
People say that publishing case.
Yeah, and there was a editorial that came out of the Mayo Clinic about that.
Yeah. Sorry interrupting you. Then I realized that most of this physician doesn't know how to interrupt this stress exercise testing. And then starting doing some courses. talk about stress test, and then started hitting about CPAT or cardiopulmonary exercise that we did. This is amazing. This is a thing. This is like opening you another
CPET, so cardiopulmonary
pulmonary
exercise test.
This will give you like more perspective data. You can measure accurate. It's a more gold standard for measuring V2 peak. And you can see how your heart work, how your lung work, and how mitochondria work in your body. Because you're on V2 peak. You know what I mean?
Yeah.
However, one thing, and then during the classes, I was teaching physiology, medical physiology. I started thinking, okay, how we can add curriculum to physiology or exercise to medical physiology. It was tough for me, So first thing I was like refused by all the faculty. They said we have a chapter, a very small chapter, is at the end of season. It's about physiology baseline stuff, like about metabolite, like aerobic, anaerobic, you know what I mean? Kind of...
Oh, different muscle fiber types and stuff.
Like
Yeah.
very APC stuff.
Yeah.
So it's not for... So then I said, okay, if I'm going to teach cardiovascular, at the end of cardio, I'm going to teaching how exercise affects on cardiac function with acute level and chronic adaptation. And then I starting to talk about athletic heart, and then about cardiac rehab. And still I get argue about this. People refuse to do that. Do you know why you refuse it? Because they doesn't know it.
Yeah.
They have no idea that. This is my experience. I've been struggling about those. And for me, to teach the student about this, how using benefit can help them.
So you're having a hard time teaching people about the physiological the physiological benefits of exercise within the medical community itself.
Yes.
You're saying,
yes, yeah.
And it's
it's not by the student; it's refused by the faculties, by the system.
Yeah.
Yes.
Because
changing
it's different. People
changing.
They don't like change.
Yeah, people don't want change. Yes, that's what happened in my country of revolution. They want to get off the dictatorship, but they don't want to change. They want to stay the same. No, we have to change. We cannot improve without change. We cannot improve without taking risk. We cannot giving the next step if we not work hard.
Yeah.
It is a part of processing of life.
And in medicine, it's such a hierarchical structure where the senior attending physician is always going to know better than the resident versus the intern. You have this hierarchical structure that makes it so intimidating to speak up about things. And I could see that, based on what you're describing, it would make sense to me why.
One thing I'm so as a future, but optimistic about exercise physiology, integrative physiology, because I went to American Heart Association meeting and American calls. I found there is a huge event during this big about exercise and treatment and cardiac rehabilitation. But I believe it takes time to resolve this.
Yeah.
Yes. And I think more doctors become awareness about this.
Yeah. I think so too. And I think
this is time. And this is sometimes there's a system. So the system need to be modified, and this take time, I think.
Yeah.
Yes. It needs change. And if you want to change, you have to fight for it.
I agree. And the way we fight right now is to continue to share this information. So I appreciate you sharing it, because especially as it relates to your research and the work that you're doing in cardiovascular medicine, and cardiovascular disease being the number one indicator or the number one cause of death, that is so avoidable. It shouldn't even be within the top 10, 15 causes of disease because of all those modifiable risk factors you're saying, right? If we can get ahead of it, we're going to see that cause of death disappear, wouldn't we?
Yeah, but there's some kind of disease not modifiable, like congenital heart disease.
I know, but so people are still going to die from it, right?
Valvular disease.
Yeah.
Yes, you need to be changed to be fixed.
I'm not saying it's going to be gone,
yes,
but it will not compete with other causes of disease like upper respiratory infections and cancer and some of these top 5 diseases. it shouldn't be up there, should it?
Yes.
Because it's so modifiable.
And there's now starting connection between cardiovascular disease with cancer. That's something I learned from my PhD. Patient who have been diagnosed with cancer, received chemotherapy, received radiotherapy, they're gonna have a long-term effect on heart.
Yeah.
They have heart failure or what's called cardiotoxicity. And this is a big issue. Now starting what's called cardio-oncology. Cardiologists interested in patient with cardiovascular disease with cancer in cancer population. And this is starting. And also there's a new era starting what's called exercise oncology. I think ACM, one of the main American College of Sport Medicine, one of the main leader on there in this topic. Yes, so more awareness about exercise in cancer population.
Yeah, I think it was back in 2018. ACSM had that roundtable announcement of exercise oncology.
During my master, so my master was created by American College of Sport Medicine. The main thing remember that I went to that meeting mainly about cardiac rehabilitation, pulmonary rehabilitation. Nobody much talk about cancer rehabilitation, but now was people talk about cancer rehabilitation.
So we're making progress.
So cardiac rehabilitation has been established, that will be established, guideline, everything has been recommended by one of the main organizations like American Heart Association, American College of Sport Medicine, ACC, but now start focusing about cancer rehabilitation. And that's why we need more research about this population. We need more funded to create good guideline. And we talk about cancer, be careful. Cancer is a fake word, is a big word.
Yeah.
Is a cancer, lung cancer, same pancreatic cancer, is same breast cancer, is same ovarian cancer, is same.
Yeah. All cancer types.
Leukemia, whatever, is a huge. So I think brain tumor. Friend of mine, she was my classmate. She diagnosed with glioblastoma as a brain tumor. And she's supposed to be attend my graduation speech, but that day she had a huge operation. Yes.
Wow.
And so cancer is bad.
Yeah. I agree though. It's such a broad term because everyone, the glioblastoma that your friend had acts very differently than bladder cancer, for example.
Yes.
But yeah. And so your message here is you're saying that as more research comes out, we're going to eventually get to the point where you can prescribe specific guidelines for cancer type, disease type. You'll have like you would a medication, like this dose of this drug for this disease.
Yeah, I think so. Yeah. Yes. Especially for cancer type. Yes. Yeah. Especially for cancer itself is dependent. Yeah.
I can't wait till we get there.
Yes.
Yeah. So
I think you have a good experience in cancer rehabilitation.
Yeah, I mean, I've seen what it can do.
Yeah,
and it's life-changing. And then that's what kind of opened the door for this, whoa, being able to see firsthand the impact that exercise has on one of the most craziest diseases there is with cancer, and seeing what exercise can do. It's imagine what it can do to these other disease conditions too. And then you look into the research and it's name me a single chronic condition that exercise doesn't influence. So, can you think of one?
Yeah, I don't know, but I ask you a question. What's the main cause of cancer? So we talk about heart, we talk about risk factors. So if we treat this risk factor, we can prevent cardiovascular, at least coronary heart disease. You know what I mean? But what's about cancer? So I'm asking a question, how we can prevent cancer? So what are the main causes?
So what we learn in medical school is
I'm smoking? No. Alcohol? Might be. Food? I don't know, man. How we get cancer? I mean, there's a question. There's a lot of... I know
there's so many what we call carcinogens that influence the...
Yes.
And you said it yourself. Cancer is such a different disease, so different things are going to cause different cancer types.
So do you think cancer is related to what? Is the climate change? Is it change to environment, industry, plastic,
I think you can relate a lot of environmental carcinogens. But yeah, I mean, we're so far away from answering the question. Do you have a hypothesis of like, what is the cause of cancer?
I have no answer, but this is one of the questions I ask myself. I mean, so I don't know. Is the cancer is all disease? Is people died from cancer like thousands? I don't know.
Yeah, actually, so there's a good book. It's called The Emperor of All Maladies by Siddhartha Mukherjee. He's an oncologist and basically just wrote about the history of cancer. And cancer, we have record of people having tumors, thousands and thousands of years ago.
How did they diagnose that at that time? How do you do histopathology, man?
So they didn't, but it's the description of cutting out a solid mass growing subcutaneously under the skin on an organ and stuff. And like there's documented surgical interventions of this disease that they, way back when we're realizing people will get this lump and then all of a sudden they die. But if you cut that lump out, they live for longer. And so this is like ancient surgery for cancer. It's really interesting. And I always tell people when I'm talking about cancer treatment and how we've made like zero progress. I shouldn't say zero progress. We've made a lot of progress, but we're still doing that old fashioned way. Our best way to treat cancer right now?
Screening.
Well, screening is a separate discussion, but our best way, once you have a tumor, cut it out. Like we're still doing what we did thousands of years ago to try to cure people of cancer. Like we still have a lot of...
I mean, this is a question, I didn't know about this as well. Is aging processes? Oh, no. You have kids, you have a cancer problem. So it's very complicated,
Yeah, we won't get into the can of worms of cancer.
I think it's this Nobel Prize question to answer.
Oh, heck yeah. Somebody discovers how you get cancer, like the actual underlying mechanisms besides just like
we can talk about this in more detail, but at the end of the day, it's very complicated and there's a lot of debate, a lot of theory about this. The question is can it be preventive or not? That's it.
Yeah.
And how? Yeah, there's some studies show that there's exercise training can prevent maybe 5-6 cancer, at least like say colon, breast, I believe, can be prevented, decrease risk of those.
Yeah, you're looking at the literature and activity, activity level in general prevents incidence or decreases incidence of cancer. So it's totally evident.
Yes. So
it's not just in cardiovascular disease.
Yes.
So for... I don't want to keep you here forever. So as we close this discussion, like any areas of research other than like what we were just talking about with cancer, but like cardiovascular disease specifically, where are we headed in that field? What is the most exciting area of research for you specifically? What are you most excited about in that field?
Two things. I'm so interested in how to prevent disease, how to improve quality of life for patient with lifestyle intervention. With exercise intervention, with diet. And with diet, I'm talking like big, like diet type, circadian of diet. Restricted feeding, fasting. And with supplement. Patient need more supplement, like creatine supplement. All this.
So the lifestyle interventions that will not just prevent but also treat these diseases, you're saying, is what you're most excited about?
Yes.
And yeah, obviously, super excited about that as well.
Yeah, so I start also now starting trend about intermittent fasting. One of them interesting area is one part. I think is one part of lifestyle intervention. Yes.
Yeah, I'd be really curious because I know we've spoken about the intermittent fasting.
I do fasting. So I do been fasting like since kid. So. I do fasting like whole month every year, like for 30 days, all day.
I'm excited for you.
One thing I'll describe it is make me light during that month. That means I can feel like I can fly. This is my feeling. I feel more efficient, more relaxed, more.
You're saying
this is a feeling.
During Ramadan specifically?
Yes.
So
I don't know, is it spiritual or because of fasting itself? I don't know. I have no answer for that.
I'm excited to, like, when you told me that you were getting into like the metabolic aspect of cardiovascular disease and time restricted feeding and intermittent fasting. I've dove a lot into the research like we were talking about. And I'm excited to see if you can answer the question of, does time restricted feeding or intermittent fasting have an independent influence without calorie restriction? Because right now, my take is it's all related to calorie restriction.
I think timing is most important because it's related to circadian.
Right.
And every cell have a circadian, have a watch, I think.
Yeah, that was my PhD.
So,
PhD dissertation.
every single cells, he has a time to sleep, to work, to sleep, to work,
and to eat.
Yes,
So it makes sense.
Yes.
Don't get me wrong.
Yes, I think one advice, maybe I'm gonna give it to everyone. He tried to do it. Just avoid eating at night. That's it. Try it.
Yeah.
So simple.
But I just can't wait till we have more data to decipher.
I read article a few years ago when I was in UNC, Colorado. Is animal, I think they use rat. They have two groups of rat. They feed them at the same amount of calorie. But one group a day, one group feed them at night. So be careful, okay, for rat. It's
They're
different
nocturnal, yeah.
They're different than us. So at the end, they give him the same amount of calorie, the same amount, but different time. They found that the rat who eat the same amount of food, amount of calorie, has a higher body weight. They get more time. Timing, I think, is one trick.
Yeah. Well, see, so you're referring to Sachin Panda's work at the Salk Institute with all the mice, and they did this multiple experiments starting back in 2012, where they came out with all these papers showing if you do this circadian influence of food, so have the mouse eat, they did like a 12 to 12 model first, where like they had access to food for 12 hours and then no access to food. And it improved this oscillatory rhythm of the circadian gene. So it improved circadian rhythm. And it was an amazing experiment or group of experiments. But that was what happened in the mice. It's not happening like that in the humans at this point. And that's what I'm saying. Like I'm not saying that it doesn't occur, but I don't think we have the evidence to suggest it yet. And I can't wait till you do these experiments.
That's why we need more for research. We need more funders just looking for that. Yes.
Yeah. So I'm excited to see as the data come out.
It's very interesting. One of the just area I'm so interested in the future to do it.
Yeah.
Yes, as a personal, I do it by myself. Yes, but is intermittent fasting is a day or night? How many hours?
Mm-hmm.
Yes. So there's that debate. Like if you back to the research or study, there's a lot of different method. The timing using the window is 6 hours, 8 hours to eat. What's time starting? What's time to stop? This and this take time.
It's a messy world, the circadian research world. So
but at the end of the day, I think stop eating at the night is perfect.
Yeah,
my own personal. That's what I've been doing. It's not just about weight, man. It's just about glucose spike and insulin sensitivity, I think.
So as we wrap up here, I'm going to ask you one question. One simple answer. It's going to be one word. What is more important for overall health? Exercise or nutrition?
Both.
All right. We'll leave it at that.
Yep. Thank you.
Hey, thanks for coming on, Salah.
My pleasure, sir. My pleasure.
I appreciate it. And I hope we can have you back because it'd be fun to talk about your creatine research. And then as you get into the metabolism side of cardiovascular research, like as you start studying the metabolic contributions.
I'll be happy
I'd love to talk about that.
I'll be happy, yes.
Awesome. All right, Salah.
Thank you.
Thank you.
Thanks again for tuning in to the Kickback Science podcast. We love talking science with all of you, and if you feel the same, you can support us by subscribing, hitting that like button, and giving us a follow on our social media pages. Don't forget, you can submit questions through our website and in the comments section of all our social media. Have a good one, everyone.